Welcome everyone to today's webinar. I'm Emily Rapley, Managing Editor with Becker's Hospital Review. We will begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into your controls panel in the space labeled Enter a Question for Staff and clicking Send. We're looking forward to hearing your questions. Additionally, in about a week following the webinar, we will be sending you a copy of the presentation to the email you used to register. At this time, it is now my pleasure to start today's webinar by introducing our presenter. Jonathan Wick has over 20 years of experience in healthcare, and he has worked in both the acute and insurance setting. He has a bachelor's degree in sports medicine and holds 2 master's degrees, one in healthcare administration and one in business. Jonathan actively serves on the Colorado HFMA board and is president of the board of directors at an assisted living facility in Boulder, Colorado. Mr. Wick has spoken at several national and state events and has developed several nationally recognized programs in point-of-service collections, financial clearance, and sharing best practices in hospital operations. Jonathan currently serves as principal at TransUnion in the Healthcare Solutions Division. Jonathan enjoys spending time with his family in Colorado, has a wonderful wife, and 2 very energetic redheaded boys. He enjoys doing anything in outdoors and is a certified whitewater rafting guide instructor. He also enjoys traveling and has visited several continents, including a 6-month stay in Antarctica and the South Pole. Jonathan, I'll now turn the floor over to you.
Great, thanks Emily, and thanks everyone for taking time out of your extremely busy day. Pardon me for disrupting it as much as the government is in spending time with you today and helping you position yourselves as this legislation has been unfolding or not unfolding as we learned over the weekend. We'll have some time at the end to have some Q&A as we go. I should finish hopefully around 20 till or quarter till. So write those questions down. There's a place you can submit them as well. We'll try to address as many as we can. And then if I can't get to them in the time that we have, I'll certainly do them as the week progresses. Our plan for today, I want to give you an overview of the ACA disruption, share some insights on how, if you haven't already, kind of put together a task force or a team or structured your organizations to meet these changes where you can, capitalize on some opportunities in time. We were afforded a little bit more after the polling of the bill Friday. Overview of kind of where we sit today with the ACA remaining and the American Health Care Act getting pulled. What we may expect from Congress and some of the other constituents on a go forward. They've indicated for the most part that they've moved on and they're talking about tax reform and certainly energy. I heard that this morning. Nonetheless, healthcare is here to stay, and its funding is certainly a big part of the government's agenda. So I do think it will come back up, but they're gonna play another game for a while and then maybe switch tables. So we'll see where we end up. We'll also kind of revisit what the ACA was intended to do, about 8 years ago, and then what actually happened and what we think may happen on a go forward from there. There's some pretty complicated slides when we get to that step, and I'll try to walk you guys through them, but they really do paint a good picture of the constituents of the provider, the payer, the patient, and the employer in terms of how all this legislation and funding has been impacted. And then finally, I'll finish with just some best practices that I've had in visiting hospitals in my role now, in my prior role as a Chief Revenue Officer, and just things to think about and ensure you have, and by all means, I want to be a resource for you at any time. We'll have a web page at the end too that we're going to share with you that talks through how we can kind of keep the conversation going. But I want to make sure that we're attacking this on all fronts and insulating revenue and making sure that hospitals are doing well, because that's what's important to our country's healthcare. All right, well, let's give a small healthcare State of the Union. So the President of the United States cabinet's been evolving over the past few months. He's been in office a little under 70 days. He appointed Tom Price. Ways and Means and Energy and Commerce committees were extremely busy over the last few weeks driving the bill. Lots of legislation to look at, though, as you all are well aware. Tax reform, trade, immigration, education. Healthcare has been taking the front seat. It was a front seat certainly during the election. President Trump has made it certainly part of his platform and has been talked about both by the media and his cabinet in terms of what they want to do. And Tom Price has certainly been very vocal about reforming some of the things under healthcare with this new legislation. The ACA has been in place for some time, and it is not something, as we realized Friday, easily changed, and there still are lots of differing opinions on it. That said, budget reconciliation is likely to occur, I feel. Things like the Cadillac tax, premium subsidies, individual mandates, and other things are still going to get touched as the year progresses, I predict. And we may or may not see, big changes to the ACA bill itself. However, you may see some material changes to how healthcare is funded from the government standpoint, from a tax base and things like that. And we'll talk through some of those idiosyncrasies, but that seems to be the strategy du jour, at least the GOP, is to look at what is where the money is going and manipulating that in a way that allows the ACA to not succeed. And we'll talk through that in detail here in a little bit. The repeal and replace bill failed. If you were in a cave, maybe you didn't see that, but the ACHA Reform Act, it was polled on Friday. I've got some information here in a few slides that will talk through that. And as I mentioned, you might see, I think we're still going to see some formative changes in Medicaid, employer, and individual mandates. The executive order that Trump had in January is still out there. How the enforcement of some of these rules happen under the new legislation is still questionable. So we really want to just understand all those different drivers and motivators as they're there. Transparency, you're seeing a lot of momentum there. It's not a word I'm necessarily wild about. I call it the T word. Nonetheless, you've seen legislation from Perlmutter at the federal level. House Representatives Bill 372 was introduced as an amendment to the ACHA last week, and it talked about providing estimates to patients in advance. There was legislation filed by the Ohio Hospital Association as well that's currently in an injunctive status for transparency bills, where they said that the cost of implementing said rules would impact patient care, and so they're kind of in a holding pattern. I reside in Colorado and have helped in the legislation here as well, and served with different bills and talked to the Colorado Hospital Association quite often, and there are some transparency bills here, and I'm sure many of you listening on the phone have some others that may or may not come up as we go. So I do think you're going to see transparency take a front seat for some of this, because there does seem to be some chips being put in front of the patient understanding what their costs are and having that help drive decisions and costs and access and things like that. Value-based care, that road's been paved. MACRA and MIPS are certainly something that are going to continue, and because they address healthcare costs and outcomes, and you didn't see much of those being touched in the proposed bill. And Secretary Price has also mentioned that he wants to kind of watch those play out with the ACOs and see what's happening, and doesn't really want to impact those, because they are a bridling mechanism at most right now, and they're not really impacting some of the other things that have had more political football thrown. How's this impacting the provider market? Well, I think disruption is going to continue. It's certainly we're in an ebb phase right now, not a flow phase. We had a big wave coming Friday, and that kind of ebbed back out. But I do think it is an ocean, and you're going to continue to see that pattern lapping against the shore, if you will, of little bills coming here and there, and legislation getting introduced. As an example, we'll talk about this in a little bit later, Medicaid has some enrollment, and ACA has some enrollment rules that are proposed right now under Secretary Price, talking about the enrollment period for the exchanges, and some other things that, that are still going to occur outside of these giant bill introductions and things that you hear about with your coffee in the morning. So, before Friday, I had a negative outlook for hospital providers with the bill, based off what the Congressional Budget Office was saying, and Standard & Poor's and some other groups talking about this bill and how it was going to impact access and costs and increasing uninsured rate significantly. I've changed that to uncertain over the weekend, just because we're kind of in a status quo, if you will, for the time being. But there are other pieces of legislation that are floating around, and certainly some politics will still occur, I think, as the year progresses. We'll see what happens in the 2018 plan year at the very least. So here's some key committees that really control, where money is spent and appropriated from a federal standpoint. Paul Ryan, we've heard a lot from him lately, but he chairs the Ways and Means Committee. Fred Upton, Energy and Commerce Committee. Mike Mulvaney of the OMB He had some comments, surrounding the impacts of the bill from a financial standpoint. You've got Orrin Hatch on the Senate side and the Health Committee of Lamar Alexander. And then, Trump did appoint Tom Price. He's a orthopedic surgeon out of Georgia as the Secretary of Health and Human Services. And he's been very vocal about what he intends for this country's healthcare delivery, both in his time in Congress and now as an appointed role as the Secretary of Health and Human Services. So I think, depending on what priorities end up on the wheel and where the politics play out, these folks certainly are names that you will see. And what's important to understand is that they all are from a similar party, although as we discovered on Friday, that party does have some fracturing in it as well. But it's interesting to see the domain of control and where that may or may not drive policy for healthcare. I put this grid together, over the last few months, I guess, and it's kind of evolved as things have changed. It's a little bit to digest, but a question I often get asked in my role is, what do you think, John, is going to happen with the rules and the all the noise that's out there, and how's it going to impact the stakeholders that play within the healthcare space? And one thing I've learned is you can't be too predictive, and you don't want to certainly close any doors. So I kind of established some valences, or is it going to be a positive or a negative impact, and then establish some timing in the effort to not be too vague. I will be completely transparent and honest with you. I had hospitals, providers at a negative at the midterm as late as of Saturday morning, just because of that bill and its impacts to them. I changed that to a more neutral impact. I think at least for the plan year that we have in place, we're going to just continue to see where we're at. I did remain keep that negative in the long term, because I do think, given some of the rules that are out there and given the just the legislative change of guard, we will see some more disruptive activities politically that certainly are not going to impact hospitals, providers in a positive manner. The AMA and the AHA have been very, very vocal to the current legislation. There was a letter called "Do No Harm" that was sent, I believe, from the AMA to President Trump, and the AHA has also had several position papers surrounding, what they feel the ACA is benefiting and where they feel there are opportunities. And I don't believe anybody would assert that it's a perfect system. Nonetheless, it certainly has helped impact the uninsured and provided more access. It has helped hospital providers' profitability, and certainly has garnered much attention in terms of talking about Americans and their access to care. Employers, on the other hand, I've kept this the same. They've been shouldering the burden of financing healthcare costs in our country ever since World War II, and given that shifting in deductibles and premiums and things off to the patient, the employer mandate certainly did not help them, and having to carry legislative rules along with all the other rules that they have hasn't helped them as well. And so I think they're going to end up in this disruption probably making out better than others, just from a financial standpoint, in that they aren't required to meet this bar or leverage the financing as they go. Consumers and patients are neutral. I do think there may be a negative impact over the next year or so as the rules change, and we'll get into those in a minute. Insurance carriers, I think they are neutral as of now, but they, may have some relief with MLR ratios or some of the exchange plan coming out in terms of offering choices and not having profitability concerns for their shareholders. I think they'll have a positive outcome in the long term. The industry as a whole, I debated. I think it's neutral now. I don't think you're going to see the industry come out of this negative after this is all said and done. One thing that's nice, gang, is that it's being talked about, right? And one of my favorite little mantras is the first step to recovery is admitting there's a problem, right? And healthcare in America certainly has its challenges, and so looking at it, be it legislatively or as a group, will have positive outcomes. We're not going to stick our heads in the sand and not look at it anymore. So I do think looking at it, regardless of your opinion or where you're coming from, will end up having long-term positive solutions for the industry as a whole as we progress. So let's talk about the bill. I'm not going to spend too much time, getting into the details here, but it had an approach of obviously repealing the ACA, replacing entitlement tax subsidies with credits. It kept the exchanges. It had a penalty if you lapsed coverage. It encouraged health savings accounts. It had innovation grants. It kind of kicked the can down the road a little bit for Medicaid funding for the max to 2020 and didn't touch that. So it was pretty neutral in terms of some of the things in getting where we ended up having some issues is it didn't address cost. And Standard & Poor's had this statement made where they said, in addition to the future growth of high deductible plans combined with greater levels of uninsured people, this could result in higher healthcare costs to consumers. And so they felt that this would actually add pressure to the industry and not help it, and came out and had a ratings statement surrounding the impact of the bill itself. Congressional Budget Office, you've probably heard this already, projected that the number of people without health insurance would grow by 14 million under the new Republican Obamacare replacement bill. And with that number rising to 24 million in a decade, that would basically reverse the efforts that the ACA had put in place for providing more insurance for Americans. And so, they said, well, who's going to pay for that? And then I've seen, astronomical numbers in the billions and millions talking about the cost of that uncompensated care. And we'll talk through that here in a second as well. Medicaid, obviously, at the local level, had some very, very heated and polarized responses. Republicans, regardless of their affiliations, did have constituents in their states that did elect to expand, and some of this may have impacted that or not. And so they felt that a complete repeal of the ACA without a replacement plan would involve some unpopularity within their state's constituents. Regardless of that, I do feel that Medicaid restructuring is probably going to happen, as does Chip Kahn. He mentions here you can't get savings out of Medicaid. I don't know where else you're going to get them. The fact is that healthcare costs are rising. They have leveled somewhat, but Medicaid represents one of the primary funding mechanisms, and Medicare, and around 57% of the country right now either have one of those two per an AHA survey. And so that is where the cost savings are going to have to come from a government standpoint, and then from a private sector standpoint, these ACOs and the MACRA and MIPS and things are hopefully going to design some innovative methods to control commercial at-risk plans as well. But if you're working in the industry, it certainly has moved from a fee-for-service to a fee-for-value and fee-for-outcome market, and that's increasing pressures to the providers as well. A House divided will fall. Republicans were short of the votes. I saw news anywhere between 50 and 35. I actually was coming off of a raft trip, and my email was lit up like a Christmas tree Friday from different folks saying, "Oh my goodness, look at the bill, may not make it," and here we are. Freedom Caucus and Coverage Caucus, made their points well known, and concessions for one group certainly repelled the other. Rodney here, he's the House Appropriations Committee chair, said in addition to the loss of Medicaid coverage to so many people in my state, denial of essential health benefits in the individual market raises serious concerns. I consider this the straw that broke the camel's back. Once this went out, the vote started swaying, and that was the end of it. And then we saw Mr. Ryan approach and say Obamacare is the law of the land. It will remain the law of the land until it's replaced. We'll be living in it for the foreseeable future. How long that future is and where we end up is yet to be seen, but this was his announcement on Friday. Another grid with just some impacts. You'll notice the bill at the top, the ACHA bill is there. Price had a bill as well. Trump had a 7-point plan. Ryan's Better Way plan. There was a Patient Care Act that was presented during the Obama administration. And HFM had an article in 2017 in January that also had many of these elements. So I kind of put them in there, but it's interesting to see where there are green checks and red X's across there. And this ACHA bill, tried to meet as much into the middle as they could. They knew that they weren't going to get much Democratic support, and so they were trying to at least align the party, and they got close, I think, but you'll notice something that's very clear on here is that the individual and employer mandate is axed consistently across all of the viable replacement plans. So President Trump announced on Friday, this was interesting, to say the least. We learned a lot. We learned a lot about getting votes. We learned about the rules of the Senate, and it'll be an experience that leads to an even better health plan, he feels. Kaiser family had an interesting statement as well. It seems the Trump administration now faces a choice whether to actively undermine the ACA or reshape it administratively, and I'll talk about some of those things here as we get into the deck. I love this from Pascal. He said, rather than repeal and replace, it could be instead called reform and retain. I think this probably has the most likelihood of getting some legs, at least some help from the Democratic parties if we can. Medical regulations could be reformed, but many subsidies could be retained, and reform might end up being repealing elements of the ACA, but the focus would be on improving the health system as a whole, not just simply, yanking it out, replacing it. I think as you heard these bills come up, every person that was against it said, you can't just yank coverage out and pull the rug out from 20 million people. We've got to come up with something that replaces it. And then the discussion and the debates happen about what that replacement plan looks like. And so Pascal kind of had an interesting reform and retain position here. We could see if that's where we're going to end up. I remember 90 days ago, repeal and replace wasn't even a household term, and now you say that, people know what you're talking about. I don't know if reform and retain will garner that much attention, but it certainly is interesting to think about. This is that executive order I alluded to earlier. He released this in January. It's still out there, and it is a policy to seek prompt repeal of PPACA. And in the meantime, pending such repeal, it's imperative for the executive branch to ensure the law is being efficiently implemented, taking all actions consistent with the law to minimize the unwarranted economic and regulatory burdens of the act. So if you're circling anything, or when you get this deck, highlight that next to the last line there. That's the big thing. And so interpretations I've seen on this executive order is, is the employer and individual mandate going to be enforced? And what does that look like? And as you saw in that grid before, those were the things that there was a resounding agreeability to. The law is the law. How it's enforced and interpreted is Secretary Price's issue. And so I think you're going to see a lot of dialogue and debate surrounding whether laws are being enforced or not in this legislation versus this repeal stuff. I think that's going to be the shift that we see as we go. So how is this going to impact the people that are on it now? Well, you pay your premiums and your coverage is unaffected. I do think there's going to be a little bit of a bumpy road in the next plan year. HHS has several rules that are being proposed that are expected to be approved here over the summer surrounding enrollment periods, how qualifying events are documented. So, hey, I lost my job, I had a baby, or I got married, those types of things, how those are documented in terms of how you get coverage. Those rules are fundamentally proposed to change, and that would make it, I think, more difficult to get onto a plan next year than it would be this year. Costs, don't get me started, but I don't think anyone thinks that the ACA has really addressed costs in any sort of material fashion. It certainly addressed access. The AHCA also did not, but we're going to continue to see these deductibles, co-insurance, and co-pays increase. The bronze deductible, $6,100 this year. The silver is $3,600. Those are up 20 and 23% respectively from when they first started, and they're up 13 and 3% respectively from last year. And we all heard, about the 26% increase in premium, and that varied anywhere between, per Kaiser Family Foundation study, keeping the same or 145% increases in an area in Phoenix. And so that, in combination with the exiting of folks from the exchange, certainly creates some fragility in that market. And we'll see, you are seeing a trend of folks pulling from the exchange market. There hasn't been many folks adding in there, and that needs to be sustained and stabilized, and I think the legislation is trying to work on that as well. Commercial and Medicare don't have any major impact changes, don't hold me to that, but these bills and what I'm talking about today, there's certainly going to be changes, but the government's not going to have much to do with them from a material standpoint. Expansion will continue in non-expanded states. I don't have the states off the top of my head, but at the minute that bill got pulled, a couple states had actually gone. I think Kentucky was one, and I'm going to go off on a limb. I believe the other may have been Ohio, but I'll double check. But the Medicaid expansion states, 2 states did come forward after the bill went through, and they're going to elect their position as expanding. And states could impact Medicaid enrollment with less oversight from the federal government. PBS had some interesting insights from that. You'll see, I think, some proliferation of the Medicaid Section 1115 waivers, which I've got a slide on later as well. That grid I was talking about earlier that kind of talks about what the ACA was designed to do. So, the government was going to put money in, the states were going to put money in, and that was going to help folks get on, and consumers would hopefully, use the subsidies or the new enrollment provisions to either get onto Medicaid or the exchange plans. And that influx of cash would certainly help. Employers would need to comply with the mandate or pay a penalty. That hopefully was going to get payers playing ball and offering plans and getting them in there and participating in the plans, and then that would ultimately reduce uncompensated care for the provider. This was what was supposed to happen in the ACA when it was launched. What wasn't in the plan is a lot of states didn't elect Medicaid or expand Medicaid. They kind of kept things the way they were, and fewer consumers came to the party. The young invincibles didn't decide to sign up. They said, I'm going to take the tax penalty. I'll use insurance when I need it. So, I've heard people say they kind of came to the party and then they left. They didn't hang out for very long. So the individual membership growth did not grow as much as we had hoped, and as much as the market had hoped, and the exchange plans are unprofitable, and you've seen some since that an exit of that, and providers also have this balance after insurance and uncompensated care issue that's starting to happen. We'll talk about the patient being a new payer here soon, but I think providers appreciate the momentum and position the ACA has put us in. The high deductibles and the cost to collect issues are indirect consequences of having those types of plans in place. Some changes that may come from the federal government. Right now, Medicare and Medicaid are in a mandatory spending bucket. Secretary Price has been vocal in saying he'd like to move those to a discretionary spending bucket. He's quoted here saying 2/3 of the current expenditures are dedicated to automatic spending programs, which are not subject to appropriations. That's pretty spooky if you think about it, because we'd be putting, our elderly and our under or uninsured into the same bucket as tanks and Homeland Security from a funding standpoint. So I'm not sure how much legs this has, but it is possible under this legislation. Per capita or block grants are things that are still out there. They were elements of the ACHA bill. They had that 2020 rule. You see what happens depending on the color of state that receives them. States would get less annual aid, and I'll talk through each of these models in just a second. Republican states that either chose to not expand Medicaid or did not want the match would certainly slash those benefits to help save state-level costs. And then Democratic control will provide more state funding where the budget allowed. Think of a 2008 reset, I was working in the hospital when we didn't have matching. Obamacare really did, expand and get a lot of folks onto the Medicaid program. First and foremost, I would argue even more than the exchanges did, and that was the, kind of the big tsunami that happened, is a lot of folks got onto Medicaid that otherwise would not have. Where that money's coming from, be it the federal government, the state government, or both, is what's going to be discussed on a go forward. Right now, we have a match program. As most of you are probably aware, matching states vary by state, population, and service. $346 billion was a match to $205 billion in state funds. States follow the rules. They also can get DISH dollars, GME payments, things like that. Under per capita, the plans certainly change based off of per Medicaid enrollee. So this is, hey, you got this many people on Medicaid, we're going to take a spot here and say that's what you get, and it gets paid up to a cap. Block grants, they don't receive any more than a set amount, and that's typically allocated among states referencing in a base year. And those caps could be frozen, and they would allow for cap payments to grow based on either a consumer price index or a gross domestic product. This provides funding certainty to federal government. They would know what that expense would look like over the next few years, or over at least the next year. And states can elect the rules and either legislate or understand that in their own budgets as they go. I'm not sure which of these are going to go, but they certainly have been talked about. I thought it'd be good to highlight, where they're at. The sources down there if you want to dig more in. The issue with these grants, and I think the issue with any health plan, is that they don't really account for the what ifs, public crises, drugs that aren't covered, or unanticipated healthcare costs. Those patients, if they are on Medicaid, would still require some sort of funding through the Medicaid program, and if they were capped funds, the state or the hospitals would have to eat that amount. There'd be windfall from a payment standpoint. So it's just something to think about as these block and cap funding plans come off, regardless of the match. So that does bear risk to the hospitals. Increasing enrollment and costs will no longer issue increased federal funding. So cost pressures may increase state to limit enrollment. They may change the benefit plans and the qualifying criteria. And fewer covered lives could lead to more uncompensated care. Becker's actually had an article this morning on the CFO review that talked about how there may be, Fitch said that there may be an uncompensated care spike under the ACA, regardless of any changes that happen, just because of the exchange changes and where we're heading with some of this Medicaid funding. And you may see a 1 to 2% increase in uncompensated care over the next year, given that. And so this is just creates some disruption challenges for population health management as well. Additional Medicare changes, discretionary spending I mentioned. Ryan, Mitt Romney and those guys remember this voucher stuff. That's certainly still out there. You didn't see legislation specifically talk about it, but that voucherization of the program is something that's on Ryan's platform. And when he dusts his knees off and kind of gets back up on the horse and figures out where they're going, and after they figure out tax and energy and gun bills and everything else, that might be something that gets talked about again. And obviously having a voucher program could have adverse actions to the older, sicker, and poorer beneficiaries, as they couldn't afford the traditional coverage as we go. Regardless of what's happening with all of these bills, you still have this long list of bulleted items that at least I feel, HFMA feels, and others feel that are going to happen. They're going to see some changes in the Medicare Advantage plans. Independent review boards might get repealed. CMMI grants can get impacted. Physician-owned hospitals, we already saw that with some of the site-neutral payments. Medigap reform may happen, combining parts of Medicare A and B. Things to strengthen the patient-doctor relationship, especially from a privacy standpoint. You may see some uncompensated care reform. MACRA and MIPS, you may see some parity in the Medicare Advantage plans, but the plans will stay. You may see some different kind of innovative models surrounding premium support. I don't know if they come in the form of subsidies and other things, but HSAs and things like that. Pharmaceutical tax, medical device tax, Cadillac tax, CHIP plans, PDUFA, and the Medicare Independent Payment Advisory Board are all things that are on the docket. There's a dedicated bill for the pharmaceutical taxes from a free market trade standpoint. Medical device tax is a component of the ACA, as is the Cadillac tax. But since they're taxes, those other committees I mentioned at the beginning can be administratively touched through something called budget reconciliation. And so just something to think about, that these pieces of legislation can come up for debate as we progress. So these slides, the next two are probably the most important ones in the deck. So if you've been kind of multitasking, it would be time to pay attention. So these are some things to think about with the disruption as we progress. Macro MIPS, I think, are going to persist. The Advantage plans are going to align with commercial insurance. ACOs are going to continue. They're all going to stay, gang. The American Journal of Managed Care said this as well, because they control spend and outcome. And those are two things that I think anyone can agree on that we need to look at. The HHS model is getting defined. Tom Price was confirmed. You saw the executive order I showed you. And Verma, who is over CMS now, came out of, I believe, Indiana, and she had a demonstration program there with these Section 1115 waivers that was very, very successful. So I think you're going to see the approvals of these waivers happen more frequently as they come in. And so that's another way to kind of allow the states to manage their own risk pool and their own money and kind of bypass some of these provisions of the ACA. Medical payment concepts, reform concepts will be debated. I've mentioned that, the block per capita grant. States will move to federal risk pools based off where we're at. You know, with the expansion, I think you will see some new states with the ACA getting pulled. Medicare could become a voucher program if that brings up. That will be extremely popular to debate. So we'll see where that ends up. But these are all things that are certainly things that should be top of mind for providers as we go through. Deregulation is going to happen in insurance. They've mentioned that. They said we can't follow these rules. We know how to manage risk. We've been doing it for 50 years. We can do it, thank you very much, on our own. We don't need the government to tell us how to do it. And so I think you're going to see in this legislation continued easing of the bridle for that. You might see some changes in guarantee issue in the individual markets. Employer-based insurance will still remain the primary source. AHA's payer mix still predicts about 50 to 57% CMS. For Medicare, Medicaid, 35% commercial, 10% self-pay, and 5% other. They release that every couple of years, and that's an interesting document to kind of look at to see where they see the predictions to happen. Health benefit exchanges, the mandates, and the insurance plan provisions will increase in complexity. Those are those rules I mentioned that are in place, are being proposed to pass in June. Transparency, as I mentioned, will have quite a bit of momentum. It is a term broadly used in the market, and it's very misunderstood. The reason I kind of take issue with the word transparency is you can have as much legislation in the world that talks about how much things cost, but unless you start talking about how they're going to get funded, all it is a bill that says, here's my price. And so there hasn't been much study that say, or outcomes that say, if people knew the price, they would change their behavior. If they knew their out-of-pocket costs, they might. And so transparency kind of needs to have both edges covered, and most of the legislation out there is like, show your price. Well, that's a meaningless number for most of us that work in the industry. A charge description master price does not necessarily impact what the costs are or reflect what those costs are to a hospital. And so looking at them and figuring out where you end up and what the patient's going to do off that. I used to say, I could tell a patient all day long that their MRI is $1,500. Now what? And so a transparency bill that affords that doesn't afford the other things. And Perlmutter's bill gets to some of those levels. I would argue some of them are burdensome, but it does kind of couple that patient and engage them financially as we progress. Unknowns and a very, very packed legislative. Trump and the legislation have their hands full, as I think any legislation has. Healthcare reform is at the top of the docket. The tax is now getting talked about. Energy is getting talked about. There's some immigration stuff, the ACA wall and everything else. Education bills, VA bills, trade, and energy are all things that need to be addressed. Healthcare was at the top of that list. As of last week, it's getting subordinated by some of these others now. And like I said, who knows when we'll come back to that other table. So after that kind of fire hose of where we're at, I wanted to end, my talk today and then address some questions on things you can do. As I mentioned, the patient's a new payer. In 2002, they represented about 10% of your uncollectible or your collectibles in your AR stream. Right now, they're about a third of that. So that's those deductibles, co-insurance, and copays. And patients are not great payers. Love them or hate them, Medicare is a very consistent payer. They pay me every month on the same day, and they may not have paid me what I was supposed to get paid, but I knew I was getting paid. Patient, that dunning cycle and statement cycle could be very, very volatile depending on where they're at. And if it's 30% of your dollars, given some of these deductibles, which are very, very high these days, that becomes difficult. I think with this disruption, either with the increase in enrollment in the bronze and silver plans, as I mentioned, a $6,100 deductible in bronze and a $3,600 deductible in silver. There's studies out there that show most patients have about $400 in their bank account that's liquid. And so that puts you $3,200 underwater on the silver plan. And so there's lots of studies out there that show how patients have to borrow money on an encounter because they just aren't anticipating that cost, and there hasn't been a proactive, financially engaged conversation. So treating the patient as a payer is an important positioning tactic for hospitals and providers. Best practices, this is from the HFMA Friendly Billing Project. Charge master pricing strategy clearly defined to make sure your volumes are retained and that your costs are closely aligned with your reimbursement. and vice versa. Insurance eligibility, verification, pre-cert, medical nec, referral authorizations, identification, kind of fraud detection, active financial counseling, including payment plans and alternative payment arrangements, and these special handling accounts. This is the blocking and tackling in a revenue cycle, gang. You got to hit all of these, otherwise you're going to leak revenue. And I know you're all doing them. How well are you doing them? Are you doing better, worse, than the same you did last week? And is this disruption going to impact that performance as legislative bills come in? Just think of each of these items as different things come in, like transparency or enrollment provisions for qualifying events for Medicaid, or funding changes happen at the state level. Those types of things, or exits or entries into the market for the health benefit exchanges occur. Where are your hospitals checking those information? Where are your folks doing that? And how's that looking is something to think about. Every access point is an opportunity to financially clear a patient, whether they're coming in pre-care, whether they're at scheduling, pre-reg, reg, or post-discharge. These are the big five, I call them. You have the time that they talk to the doc that they're getting something ordered, the time they call you to get it on the books, the time someone makes a call to them or they make a call to you to confirm things, the time they show up, and before they go home are five big gates that you could look at to ensure that you've financially cleared a patient and established funding mechanisms for them, and so that everyone's on the same page in terms of who's going to fund that care and where that funding is going to come from. This screening allows you to segment those accounts. You can put them into FPL buckets, ability to pay buckets. This is kind of the secret sauce now is bad debt segmentation. Put the high-risk patients into a bucket, let your team work on them, and that high risk could mean one of two things. I don't have a funding mechanism for them, or the funding mechanism is something that they can't afford, and figure that out as they progress. Hospitals that do this have between a 10 and 30% lift when they're stratifying their bad debt. That's significant. And so, take a look at that and understand how you're going to stratify that either pre, during, or after service to capitalize on those five opportunities that I mentioned. This is an example of a segmentation bracket, self-pay or high balance after insurance. You guys can kind of let your fingers do the walking. What's important are the colors over to the right. What does your charity policy say? What does your bad debt and collections policy say? How are you discounting? Are you stopping the line as things happen? Are you allowing things to happen for free, or are you establishing funding mechanisms as you go? Those are all important things to think about as you progress. This is an example of what a batch can look like if you did it pre-service. You can also do it post-service, depending on how you position your patient population. But the segmentation, I think, is going to become increasingly important as you establish your risk with all of this disruption. Another strategy is to discover coverage, and if that coverage is not there, then to find a funding mechanism outside of it, be that charity or Medicaid. If you can't find them, if after that you're to determine once you've discovered what the coverage is or what the coverage is not, how is the patient or entity going to pay you? What is the likelihood of payment? And then differentiating between that ability and likelihood of payment is kind of the key to the kingdom if you can do that with all of your patients. And then certainly putting these into the right lanes and letting your teams work on the right patients at the right time for the right reasons. Those of you who have been on my talks before have seen this workflow. There's a toolkit that we can get you as well. But this kind of has a happy path on the left. Insurance is there, insurance is covered, the auths are in place that meets medical necessity. I've done a estimate, the patient can afford it, they're going to pay me. The middle path is a disruptive path. It doesn't meet medical necessity. I can't verify eligibility. The patient can't afford it. And over to the right is an assistance path. But it's kind of a good checklist to follow as you go. And I've got more information on this if you need it. High balance patient workflow helps you through those segmentation buckets, as I mentioned. And more importantly, over to the right, how is your early out self-pay functioning? And how is your third-party collection? I'm seeing a trend of where that's starting to be brought back in-house with some of these tools, to where you're not paying some other guy to go get your money, or letting them work on the hard accounts, but you're collecting the easy accounts. So these checklists and gates are all very, very important to get at whether the person's eligible, whether the insurance that they have or not is covered, whether or not they can afford it, and whether or not you have a likelihood of collecting it. And using these things in terms of either electronic transactions, manual transactions, your own homegrown tools, or third-party tools are key to making sure that you can succeed as things get disrupted either by your own state level government or our friends up in Washington. I want to keep the conversation going, gang. Those of you that have attended this will get an email from us talking about a LinkedIn group that'll be exclusive to you. That'll keep the conversation going. And when that invitation comes out, join in there, and you could, agree or disagree with what I've said today, provide some more insights. But I really want to kind of keep it going because I think the more of us that are talking about it, the better we'll end up. And then this is also going to be a patient access learning portal for us to talk through, resources and best practices and share them. And it's an exclusive site from TransUnion that we want to give you guys. And please feel free to sign up. And I promise it's going to be more about thought leadership than anything else. And it's just going to be a place for us to all talk about what's going on and how we want to attack it. That, in a nutshell, is where we ended up. So I'll open it up for questions.
Thank you, Jonathan. That was a fantastic presentation. So we will now begin today's question and answer session. As a reminder to our audience, you can submit any questions you may have by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. And we'll try to get through as many questions as we have time for today. So to kick us off, our first question from an audience member is, do you know if there will be any impact to the veterans' healthcare or military health system?
I haven't seen a lot of legislation about the VA benefits and others at least proposed, and I follow this stuff pretty closely. I'm an NPR junkie. My radio's tuned to it often, and I subscribe to Becker's and follow that. I have not seen a lot. I think we kind of have to learn how to crawl before we walk, before we run, and I think you will see it after we start figuring out the ACA stuff. But it's kind of taken a second fiddle, if you will. It got a lot of attention from an access standpoint last year in terms of, long lines and things like that, and veterans wanting to get health care. You didn't hear a lot of it during the debate. You heard more about, how health care is going to get funded and how the tax base should or should not have a role in that, and how we're going to address cost and access, and how the states are going to manage this, and whether the exchange plans have some fragility. You didn't hear a lot about the VA, and I haven't either. When I do, I'll let you know, though. So join that form at the end, and we'll put it in there.
Sounds great. Thank you. So our next question is also related to the impact of recent political events. Do you know the impact to prescription drug access for Medicare patients?
Yeah, so Part D of Medicare came under quite a bit of debate, during the last legislation. It hasn't came up now. There is a pharmacy bill that's out there, and I'll try to pull it for this group and post it in that forum that's being debated now. And that kind of went quiet when everything else bubbled to the top. I don't know that it's going to touch the Medicare benefits necessarily. It's going to talk about more on how pharmaceutical are purchased and the cost of them, and then the thought is that if the country and patients and providers spend less on drugs, healthcare costs will come down. And to afford that, we need to fast track things like the Cures bill, that allowed FDA rules to somewhat be lessened a little bit, and then maybe free market trade, love it or hate it, for pharmaceuticals. There's two sides of the coin on that. The rules are in place to make sure drugs are safe and being provided in a manner to where they're meeting the needs and demands. When we're relying on other countries, it may be cheaper, but the surplus may not happen, or the demand may outweigh that. So but all those things are being debated. That bill is looking at all of those pieces, and I'll get you that bill, and we'll take a look at it. I haven't seen it get presented. I got a buddy in Washington that I'll ask as well to see if we can see if that's coming soon. But it kind of sat down on the bench while this other stuff was being played out last week.
Sure, that makes a lot of sense. Thanks for clarifying that. So for our next question, how much of a focus do you anticipate providers will place on improving the patient experience in light of all these uncertainties and reimbursement concerns? What types of approaches do you think they will take to better achieve this?
I see it as the forefront. Something that wasn't in my deck, but it's in a lot of others that I've seen and also done is that you're getting paid now, gang, from CMS as part of the elements of those HCAP surveys, right? And so, it's not on whether you saved their life or not, or made the knee better, and those types of things, although those are all outcomes and great. The patient, though, when they're filling that survey out, were you nice? Did you help me understand my bill? All of those things are things that are going to come up. I think, one of the mantras I have as well is that a patient's first and last experience with a provider is typically a billing one. Hi, Mr. Wick, welcome to my facility. I need your ID and insurance card. And then a bill comes in the mail. And so those two things need to be very, very elegantly presented and provided to the patient to where they feel they have an advocate and a partner as they navigate their healthcare costs. And that needs to be the mantra. I always said the goal is not necessarily to collect money. The goal is to help patients understand their costs and fund their care. And if you make it about that, that experience becomes way, way more collaborative than polarized. There's a white paper coming out too that we're going to do that talks a lot about those strategies and how engaging the patient financially and having them be a part of that process versus kind of sitting on the sideline and waiting for an envelope in the mail causes issue.
Perfect, thank you. So we have an audience member here that would like to have you explain budget reconciliation.
I'd like the audience member to explain it to you. I'm teasing. So budget reconciliation is a process that doesn't require vote through the House, if I believe it. So budget reconciliation involves presenting a tax bill through those committees that I mentioned, and then having it passed very quickly by those committees and then being presented. And then what can happen in those is that you don't necessarily repeal a bill or present another piece of legislation. You present regulations and other things that impact fundamentally how that bill is going to be governed or administered from a budgetary or tax standpoint. A perfect example of that is open enrollment periods for the exchange, or having a penalty applied for a patient that, or for an enrollee that didn't imply their tax benefits. The executive order that Trump had talked through making this less burdensome. So the IRS could come up with a budget reconciliation rule, pass it through one of those commerce committees and say, hey, we're not going to impose the penalty anymore for taxes on that. Yes, that impacts the bill. Yes, you'll hear debate about whether or not the ACA is being followed, but we've heard all that stuff before, right? So the budget reconciliation efforts create a path legislatively that don't involve impacting a bill directly, is the short answer.
Perfect, Jonathan. Yeah, that was a great overview of a fairly complex process, so I appreciate it. All right, our next audience question. How will these changes affect self-funded employers for employee group health coverage?
Yeah, that's a tough one. So most health plans are governed by something called ERISA, the Employee Retirement Income Securities Retirement Act. I butchered that, but those of you who've worked in the industry long enough know what ERISA is. A self-funded or ASO, or Administrative Services Only plan, falls outside of those rules. And they also, I think, fell outside of some of the ACA rules. And so if you're a self-funded plan, you kind of make your own rules. You set up a plan that has, a risk pool set up by what the company feels it's going to put in there, and it's going to self-fund, the risk against the claims risk in their own pool and do that. That said, if you are an employer and you offer insurance to a health plan, you have to follow, per the ACA, this employer mandate. This employer mandate says that you have to offer health plans that have a minimum essential benefit, and if you're greater than 50 or more, you have to have this. It has to be a plan that has these benefits in it. It has to be a plan that has a certain level of affordability to it, and those types of things. But an ASO plan may have provisions in it that cover certain things differently, but they cannot be less than those others. I hope I interpreted that the right way. The ASO and self-funded plans are extremely complicated under ERISA, but that's my understanding. And please reach out to me, anyone, if you feel I'm off base there.
Thanks, Jonathan. Our next question from the audience is about prospective risk. How do you use risk models to determine utilization of services such as emergency or inpatient services?
Yeah, so, I think this is, population health management 101. So you're seeing a lot of traction in this area, especially, with the value-based care stuff and the ACOs, managing, what predictive analytics you can apply to a patient population to improve an outcome. So outcome improvement measures that I've seen are admissions to the ED over a year period by the same patient. Is that 1, 6, 10, or 60? And why is it 60? Is it for pain management? Is it for cardiac arrhythmia? Is it for esophagitis? What is the condition that's causing that? And do you have good mechanisms in your ED to triage that from a hospitalist standpoint or other thing, and to let people know that, hey, this is a frequent flyer to our emergency department, or every time we admit this patient, they stay in-house for 25 days. What are those care paths and what do those look like? Most hospitals and providers have analytic packages to kind of look at that as a one-off, but they don't have holistic alerts and kind of a change path or an actionable step that changes or at least advises physician or clinical behavior as things are happening. Hey, Dr. Smith, this is a patient that has been here 10. This is the 11th time they've been here. You did admit them last time, but Dr. Jones did. And when Dr. Jones did, he was here 25 days, and it wasn't at your hospital, it was at another hospital. I think the sharing of that information will also help with some of that. But that analytics really will help drive, I think, utilization down from an outcome standpoint, because I think hospitals are often put into a shotgun role where they have a patient, they got to do what's best for them. Sometimes that's watching them, sometimes that's up on the deck, and then now they've got a discharge and a disposition issue, and a skilled nursing or an assisted living or a home health may be difficult to establish given the rules, especially if they're on a government plan. And so managing that whole continuum on what's the best level of care for that patient as they encounter each level with analytics can drive that.
Perfect. Thank you very much. So we have time for about 1 or 2 more questions. So try to squeeze these in. The next question, do you think any other insurance companies will come back into the marketplace next year? Our county only has one to choose from that is not in network.
Yeah, boy, I feel for you. I don't know if you heard my haul. There is a great Kaiser Family Foundation web page on this that talked about the choices of exchange plans over the last 3 years, and I'm a big KFF.org fan, and I'll try to put that on my forum as well, and so you can kind of go out there and go look at it. It talked about the exchange plan trend being an exit, not an entry, and as I mentioned in my talk, you're seeing a lot of efforts in the new legislation and the existing legislation. I think that is one bipartisan issue that they all agree on in stabilizing that market. They've got to figure out a way to make this a venture that is desired by the insurance company, the young invincible. We already know that the ill and the underinsured are ones that are going to go in there and get it. That's part of the reason why we've seen the exits. But to make that kind of grow, because we know that a guaranteed issue individual plan market will have such a bad risk pool that that's not sustainable over time. And so these exchange plans need to come up with a way to allow for that to happen. Unfortunately, that has not been the trend, and you're seeing fewer and fewer choices and more exits. And I think we're going to see more of that unless there's some lightening of the load for the insurance companies to participate, because they came in and had actuarials look at that PM stuff, and a lot of those actuarials were surprised by how little folks signed up, like you saw on that circular grid that I showed you.
Definitely. Thank you. So we have time for one more question. Which will have a bigger impact on hospital systems and why? Number 1, the phenomenon of high deductible health plans, or number 2, risk-based contracting through CMS or commercial payers?
I think number 2, just because that's going to impact all of your cheddar. How you handle high deductible health plans is going to be a function of the maturity of your revenue cycle. There's studies out there that say a lot of patients want to and will pay you on a high deductible plan. It's just a matter of getting creative and moving off of a traditional billing cycle. I think risk-based plans, are different, right? If you don't make that finish line and come back, you're going to end up investing money and not getting that coming back to you, and that will impact your P&L significantly. Dollars down the road, you all have been collecting money for patients for some time. It's integral and imperative to collect it up front and to have a financially engaged process for it, because that bad debt risk issue is happening, but it's not nearly to the magnitude of having a risk-based contract, because that's in some hospitals, billions of dollars to the millions of collectibles that you might be getting from your patients.
Definitely. Thank you very much. So it looks like that's all the time we have today. I want to thank Jonathan. That was an excellent presentation, and thank you to our audience for participating today. Enjoy the rest of your day, and we look forward to having you join us for future webinars.
Thanks, guys.